Welcome everybody to the PCR studio in Paris. We are extremely happy to host this PCR tricuspid focus group webinar today on the TRI.Fr study, which is a study just presented at ESC and comparing TriClip, transcatheter edge-to-edge repair for the tricuspid valve and medical treatment to medical treatment alone. And this study has been presented by Ervan Donald, the PI, so we want to congratulate him, and he's just sitting on my left. For the discussion of this study, I have a fantastic team with me that you will see here in the studio with Victoria Delgado from Spain. Hi, Victoria. Volker Rudolph from Germany, and of course, I already mentioned him on my left, Ervan Donald from Rennes, who just presented the TRI.Fr study in London. The objective of today's webinar are the following. So we will see the result again. Ervan will present the study again. Then we will discuss together the interpretation of the result of this randomized study, which is the second one, investigating transcatheter edge-to-edge repair and comparing it to medical treatment. And then we will try also showing you some example to understand what are the consequences on clinical practice of this result. Something extremely important, we want really to interact with you looking at this program. We have here an iPad where your question will come directly to us, and we will give priority to the answer to this question at any time. So just feel free to ask questions, and we will try to answer as good as we can. So I just want Ervan to give you the word and to present the result of the trial so that we can start the discussion. Thank you very much, Ervan.
Thank you very much again for providing me this opportunity to be with you today to discuss, thanks to the PCR focus group, this study that we did in France and Belgium. So this is a study about the transcatheter edge-to-edge repair versus the medical treatment in symptomatic patients with at least a severe tricuspid regurg. And of course, you know that we have to take into account the tricuspid regurg. We know the patients that we see in our hospitals, in our clinical practice, they are severe. They have comorbidities, they might be old, but we really have to take into account the tricuspid regurgitation. It has been consistently demonstrated that these patients with TR have a significantly worse prognosis independently of the pulmonary pressures, but also independently of the left ventricular ejection fraction. So the tricuspid regurg is a marker of prognosis. But do we have to treat this tricuspid regurg? I think that we need studies to demonstrate that we have to treat these patients. So we did in France and Belgium this study comparing patients that were symptomatic despite the medical treatment and who were ineligible for surgery. And we compare patients with the optimized medical treatment versus the TriClip plus the medical treatment. And we assess the results at 1 year follow-up. For that, we use a clinical composite score, and I want to provide you details about this clinical composite score. So at 12 months post-randomization, we looked for the occurrence of major cardiovascular events, the change in NIHA class, the change of a patient report outcome, which is the patient global assessment that you can see on the right part of the slide. And then, according to these three parameters, one patient can be improved if there is no cardiovascular event and if there is a favorable change in the NIHA class or the PGA. A patient can be unchanged if there is no cardiovascular event and no change in NIHA class and PGA, or a patient can be worsened if there is a cardiovascular event or a decrease in PGA and NIHA class. So the secondary endpoints are the change in the tricuspid regurgitation grade, the change in the quality of life assessed by the KCCQ score and the PGA. We look at the same endpoint that the one that was the primary endpoint in TRI-Luminate Pivotal, which is a hierarchical composite endpoint, including all-cause mortality or tricuspid surgery, time to heart failure hospitalization, and an improvement of at least 15 points in the KCCQ score at 12 months. We look at the major cardiovascular events, the cardiovascular deaths, And also we look at the safety endpoint, of course. 24 centers were participating to that study, and really I want to congratulate them and to thank them for their work, because we did this study in 2 years, and of course there were also people involved in the committees, and these people did extremely nice work. The pre-inclusion criteria were that the patients have to be symptomatic despite the medical treatment. These patients have been decided to be ineligible for cardiac surgery according to the local health team. And these patients have to have a severe tricuspid regurg. So if the local heart team decided that the patient could be suitable for the study, then this center have to send the images to the core lab to check for the severity of the tricuspid regurg and to check for the anatomy of the tricuspid valve and to make sure that the patient could be suitable for a TTR therapy. And then each patient had been discussed by the investigators and the clinical eligibility committee to make sure that the patient was optimal to be included in the study. The key exclusion criteria were that, of course, the patient shouldn't have been treated for something else in the past 3 months, the LV ejection fraction shouldn't be lower than 35%, the patient shouldn't have a too severe renal dysfunction or a too severe hepatic insufficiency. And the pulmonary pressures should have been normal or at least lower than 60 mm of mercury for the systolic pulmonary pressure. So the patients were pre-included in each individual center according to the clinical evaluation, to the 6-minute walk test distance, the right heart catheterization, and of course the TEE and the TTE. Then the images were seen by the core lab and the patients were discussed with the eligibility committee. Then the centers have less than 14 days to do the randomization and to plan the intervention if the patient was selected for the TTR group. And the follow-up was done at 6 weeks, 6 months, and 12 months. The results. So we screened 404 patients, and as you can see on the slide, 50 patients were excluded according to clinical criteria. 50 patients were excluded according to anatomical criteria. And then 148 patients were randomized in the guideline-directed medical treatment arm, and 152 patients were randomized in the TTR arm. You see the baseline characteristics of these patients as compared to the main studies that have been published up to now. And you can see that 40% of our patients have been hospitalized in the past 12 months. You can also see that the prevalence of severe renal dysfunction was low, and we will probably discuss that afterwards. And the prevalence of a pacemaker or a lead across the valve was 14.7%. These patients were mainly women, and these patients were all symptomatic. If we look at the echo data, you see that these patients have mainly a massive TR with a preserved LV ejection fraction, a preserved RV function. But the gap between leaflets was lower than 10 millimeters. If we look now at the medical treatment, you see that the treatment has been optimized before the inclusion, but also has been optimized after randomization, taking into account especially the SGLT2 inhibitors that came in France during the study. The main endpoint, as you can see on the slide, at 1 year follow-up, 74% in the TTR group improved, as compared to 40% in the guideline-directed medical treatment arm. It means that the difference between both arms was highly significant. So the study is positive, And if we look at all the parameters that are in the hierarchical clinical composite endpoint, you see that all the parameters are in favor the TTR arm, the change in the NIHA class, the change in the PGA, the rate of hospitalization, the rate of death. When we look now at the secondary endpoint, and the first of them is the change in the TR grade, and you can see that in the TTR group, 71% of the patients have a mild or moderate TR at 1 year follow-up, and the difference between both arms is highly significant. If we look at the quality of life using the KCCQ score, you see that the KCCQ score was the same at baseline, and the change was only observed in the TTR group. And the absolute difference between both arms is 14.5, which is quite surprising and extremely interesting. If we look now at the hierarchical composite endpoint, that is the same that was the one that was used in TRI.Luminate, you see that the win ratio is 2.06, and it's highly significant. If we look now at the major cardiovascular events during the follow-up, you see that the tendency is in favor of the TTR arm, but it's not significant. But I would like to emphasize one point. 121 patients were hospitalized in the 12 months before randomization, but only 35 during the 1 year follow-up, with a 1 year mortality of 3.4%. Looking now at the device-related adverse events, you see that the implantation of the TRI-clip was extremely safe, with a rate of SLDA of 5.2%. Most of the patients have been treated with 2 clips, and most of these were wide clips. So this is a summary of the study, and you can see that all the parameters that have been assessed at 1 year follow-up are in favor of the TTR group as compared to the guideline-directed medical treatment. So I think that we can conclude that the TTR improves safely and significantly over a period of 12 months after randomization the clinical composite endpoint in patients with at least severe and symptomatic tricuspid regurg. The TTR was superior to the guideline-directed medical treatment with a significant reduction in the tricuspid regurgitation severity. We will be able to discuss also that the medical treatment has been optimized, and the follow-up is something that is quite interesting because the risk for an event during the follow-up was much lower in TRI.Fr than in previous registries and TRI.Luminate pivotal trial. Thank you very much.
So thank you very much, Erwan, and congratulations for all this work, for all the center, including patients in your study. So if I summarize, we have a positive study for the transcatheter edge-to-edge repair compared to medical treatment, mainly driven by patient-reported outcome, quality of life. And one of the very important points we can maybe discuss is the lower mortality compared to the other study, TRI.Luminate, that has been published last year. How do you explain these differences in terms of event, and what are your take on this? That was almost double in TRI.Luminate, the mortality at 1 year, almost 7%, in your study around 3%. So what are your take on this?
I think that we have to acknowledge the fact that every single patient have been discussed at least once with the eligibility committee, and most of the patients might have been discussed twice or 3 times before any inclusion in the study. It means that the heart failure specialist did a very nice work trying to optimize the medical treatment before any inclusion in the study. And we were extremely attentive to make sure that every single patient that have been included in the study might have a prognosis driven by the tricuspid regurg and not something else. So it's probably why we have such results at the end.
And I think, and this may probably explain also some of the other differences in terms of NYHA class, because you put a lot of emphasis on optimizing this patient and including them in the right time, also with an anatomy which is suitable for edge-to-edge repair. Was that an important decision criteria as well?
Yes. If I may, I should say that the management of patients with a tricuspid regurg is a matter of an intervention, but not only. We really have to have a clinical pathway using all the capabilities of the heart failure specialist, the imagers, and the interventionists. The heart failure specialist is extremely important. The imaging part is also extremely important. And we know that if we want to achieve a good result in the cath lab, we have to select patients with a suitable anatomy, not too many leaflets, not a too huge gap, and this has been looked at very carefully during the study.
You mentioned the imaging specialist. Victoria, you are an imaging specialist working for selecting also patients with tricuspid regurgitation. What are your main images you need? What is the workup you need for this patient? How difficult is that? Maybe you can give us some insight on this.
Yes, I think that these new therapies have elevated the attention that we have now for the right side heart, and particularly the tricuspid. And I think that before starting any evaluation here, we need to make sure the patients are as dry as possible, because that can change very much the way you evaluate the anatomy. And as Erwan said, the anatomy of the tricuspid valve, whether there are more than 3 leaflets, as sometimes we can see, and the mechanism that is causing the tricuspid regurgitation, these are the 2 main parameters to evaluate and to decide whether the patient can be eligible for edge-to-edge repair, or also not forgetting the right ventricular function and the presence of pulmonary hypertension that in the trial was one of the exclusion criteria, for example.
So a very anatomy-based selection that ensure that you have a good result at the end. Volker, maybe you're an intervention cardiologist, very experienced in the treatment of tricuspid regurgitation patient. What is your take on the safety that has been shown in the study, the complication? Is that what you were expecting?
Well, I don't know about expecting, but I mean, I think it has to be emphasized that again, in a controlled trial, the interprocedural rate of death, complication rate was really low, rate of death was 0. And this highlights how safe this procedure really is. And if we look at the SLDA rates, they also compare very favorable. I mean, with Triluminate, where we have seen 7%, here in TRI.Fr we have seen 5%. And I mean, it's even comparable to the BRIGHT registries with very experienced centers that were participating there. So I think it's very, makes one very confident about the therapy.
Okay, thank you very much. We are still expecting your question, so ask your question and we will of course answer it. But Volker will keep the word and give us his take-home messages on the study and show maybe also some example from your practice how this translates into clinical practice. Volker.
Well, thank you very much. I mean, I really want to start also with thanking Erwan for doing this important trial. And together with Triluminate and, of course, TRI.Fr, we have now 2 studies that really show that this therapy is beneficial for our patients. And I want to use the next minutes to highlight my main take-home messages from the point of view of an interventionalist. And I want to do this by focusing on patient selection, which is still, I think, the most important point. And the best way to approach our patients, I think, is stepwise. So the first question we should always ask is symptomatic tricuspid regurgitation really the problem that this patient has? And this is something that I want to pass on a little to Victoria to discuss. And once you're sure about this, I think the next steps, the next questions would be, will the patient benefit from a potential therapy? And can we perform edge-to-edge repair successfully in these patients? And for the assessment of the potential benefit for the patient, I think the TRI score that was published last year by Juliette Dreyfus in the European Heart Journal is a very helpful tool to help us to find an answer here. And what I was trying to do here was to put the trial results and the baseline characteristics of the cohort in perspective to the TRI score. And what we see is, and this is very typical for a tricuspid cohort, that almost all patients are above 70 years of age. But if we then look on, we see that with regard to New York Heart Association class, with regard to furosemide dose, renal function, there are about half of patients who fulfill this criteria. And if you look at right-sided heart failure signs, LV ejection fraction, also RV dysfunction, the prevalence of these components should be very low, so that it's probably fair to say that there were not many patients in the trial with a TRI score above 4. And this is, of course, in perfect alignment with the publication of the TRI score, which showed that only patients with a successful procedure who have a TRI score that's not higher than 5 will probably derive a benefit from the procedure. And a typical patient, I brought one example here from our center, is shown here, shows the 79-year-old lady diagnosed with HFpEF, no coronary artery disease. She presented with clear signs of right heart failure. Her hemodynamics show post-capillary pulmonary hypertension, and as you can see below, the TRI score for her would be 4, so a typical TRI.Fr candidate. And if we now have identified a patient that is likely to benefit, the next step should be to look at if we are confident to perform a successful procedure. And maybe here in the future, we should be a little more selective. I think it was, if we look at the trial results, we see that TR2 or less was achieved in 71% of patients, which is a very reasonable result. It's very comparable to what we see in routine registries nowadays. But I think in the future we could really be better. And I mean, if you look at the inclusion criteria that was given in this regard, it was only a leaflet gap of 10 or smaller. And probably if we would be more selective, we could be more confident to achieve a result of TR2 or less. And one tool that could be used for this is the recently published GLIDE score, which is a externally validated score, which in addition to just looking at the gap, and we have a more conservative estimate of the gap here, also looks at the location of the jet, at the image quality of at the density of chordae, and also at the morphology of the jet in the on-fuzz view. And if you have a score of 0 or 1 here, then you can predict a TR of 2 or less in 97% of cases. And given that we have other treatment options, which we will probably discuss later, this is really maybe the way we should go forward when evaluating patients for TIA. So this is our patient, and this was our initial TOE that we performed. And as you can see, there was a rather large gap. You can best appreciate this on the right top panel. On the right lower panel, you can see that the on-fuzz morphology of the jet was rather irregular, extending to the anterior posterior commissure. So clearly a GLIDE score that was higher than 2, but then we recompensated her, and when she came back for the procedure, you can see that the gap disappeared after recompensation. Only a central jet left, GLIDE score of 0, and with 2 devices, we could eliminate TR. So really, I think my main takeaways are that we should have a stepwise approach. TRI-score has shown us that we can derive benefit from this therapy. We should not wait too long for this therapy. We should maybe use TRI-score with a maximum of 5, and we should use a more advanced approach to technical assessment and morphological assessment of the valve.
Thank you very much, Volker. I think a very clear presentation with a very impressive case where On one side, you use score to optimize the prognostic of the patient. On the other side, you optimize the patient clinically to change the score and to make your patient suitable for the procedure. And I think that's very important to understand that the patient included in the TRI.Fr study were patients that were suitable for edge-to-edge repair, and that was one of the main inclusion criteria. There is a question from the audience regarding the anatomical criteria in TRI.Fr. What was the main criteria you were looking at, and you would advise also to look at when assessing the suitability for edge-to-edge repair?
So I think the main message is that the gap between the septal and the anterior leaflet shouldn't be greater than 8.5 millimeter, and the number of leaflets shouldn't be greater than 4, especially if we start with treating the septal and the anterior leaflet. We should make sure that the posterior leaflet is not too complicated to treat, because if we have several scallops of the posterior leaflet, it might be difficult at the end to achieve a very good result.
Thank you very much. I think that's extremely important to look in details into the anatomy. Erwan, I give you the word afterwards. I just wanted to ask Volker about the management of the patient you just treated right now. What is your management afterwards? Do you maintain diuretics? Do you control the patient after this? What is the care after such a procedure?
No, it's a very important question, and I mean, the treatment after the procedure is as important as the treatment before, so we optimize patients before. Sometimes you will admit them to the hospital 2 days before the procedure, and then after the procedure, it's very important, I think, to maintain diuretics at the dose that patients had before in order to preserve the result, and if you reduce diuretics, this should be done much later.
Thank you, Volker. I have maybe just a small question for you. We shouldn't wait too long, but is it sometimes too late?
Yeah, I mean, very, very good question. For certain, I think sometimes it is too late. I think one thing that should definitely be prevented is to have liver damage. I think this is, for me, always a warning signal somehow. And shows us that we have to look at the patient in total, but also if we just look at the valve and the technical feasibility. I mean, TEER has its limitations, but all the other procedures we have, they do also have their limitations. So if we really wait too long, if the gap gets above 10 millimeters, it really becomes difficult for every therapy. And I mean, seeing the safety that you showed in your trial, I mean, there's no reason to wait.
Thank you, Volker. So now we can ask Victoria Delgado from Barcelona to discuss the heart failure specialist point of view. What do you think about the result of the trial according to your specialty?
Thank you very much, Erwan. And I think that this evidence that is accumulating gives us a lot of expertise and a lot of learning points for when we are selecting patients. And I just want to start with, again, hammering on the key anatomical criteria for selecting patients for the TRI.Fr. This was initially published with the design trial paper, where you can see that the main criteria were the regurgitant volume greater than 45 mils and a surface of the orifice, the regurgitant orifice greater than 40, which is consistent with at least severe tricuspid regurgitation, but importantly, the vena contracta should be more than 7 millimeters, also indicating severity of tricuspid regurgitation, and the only anatomical criteria, as we were saying, was the gap between the leaflets, initially less than 7 millimeters, but then afterwards changed to 10 millimeters, knowing that also these patients could be suitable for this therapy. And as you just said, Erwan, perhaps not going further than 8.5 would be the sweet spot. But what do we have still in our clinical practice, and that's the case that I want to bring you. We have still receiving patients that are perhaps too far and too diseased for this therapy. And as it has been said, we need to optimize these patients medically in order to try to image them again as dry as possible, and trying to improve the anatomical suitability for this therapy. So this patient is a 71-year-old female who has hypothyroidism, obstructive sleep apnea with a low adherence to CPAP, and with permanent atrial fibrillation, who refers dyspnea class 3, and she has decided not to go out from home because every time she walks she has liver pain. She has been admitted several times at the hospital as well, and the last echocardiography, when she was in the optimal conditions with the maximal medical therapy, she had an ejection fraction of the left ventricle of 54 and a torrential tricuspid regurgitation, as you can see here, with a very large gap of 13/16 millimeters. You can see here in the continuous wave Doppler when we try to estimate the pulmonary arterial pressures that are not elevated, but actually this type of signal with a V shape is not reliable to assess the pulmonary pressures, because it indicates that the severity of the tricuspid regurgitation is very significant, and actually it can also give an impression that the right ventricular function is reduced. Now, when we evaluate the anatomical suitability and also the glide score, here you can see on the transesophageal echocardiography that regurgitant jet is central, diffuse, the chordal density structure is kind of modest, and when we evaluate the regurgitant orifice is kind of a star shape, and here on this three-dimensional echocardiography on end-phase view you can see that there is a very large unique anterior leaflet. The posterior leaflet seems small and the septal as well, but it's a very large gap. Because we had the doubt whether the patient had pulmonary hypertension, since on echocardiography cannot be reliably assessed, we performed a right heart catheterization, and you can see that the pulmonary arterial pressure mean was 19, the wedge pressure was 12, the right ventricular pressure was 32/5 with an end-systolic or telediastolic pressure of 13, and the cardiac output was 5, a cardiac index of 2.9. So the patient was discussed at the heart team, and it was decided that due to the comorbidities and the right ventricular function dilatation, surgical repair would have been also not very successful, and due to the risk was considered not for surgery. But then, is this patient suitable for edge-to-edge repair? It's rather difficult. So if we look again to the glide score, you can see that it's 3, and if we look at the clinical score, the TRI score is 6. So the TRI score 6, as Volker showed, is the one that is starting with the higher risk. And if we pursue to perform a transcatheter therapy, we need to make sure that it's going to be successful, because otherwise the prognosis is poor. And with this anatomic score, it's going to be difficult to just tackle it with an edge-to-edge. What do we have currently? So if we don't pursue for an edge-to-edge repair, then we need to think about direct annuloplasty perhaps, via transcatheter, or a tricuspid valve replacement, or eventually an heterotopic valve implantation. In our case, we have the possibility to perform percutaneous annuloplasty, and as I said, it's very important to strive for residual moderate or less tricuspid regurgitation in order to improve the outcomes of the patients. This has been shown, for example, in a sub-study of the TRI-Illuminate trial. So we perform a CT to assess the anatomical suitability for this device, and you can see that it was a very large annulus. We need to implant a very large band, and in principle, in terms of risk of damaging the right coronary artery was low, with only 2 anchors close to the right coronary artery. We performed the procedure, and we were rather happy with the result, because from that torrential tricuspid regurgitation we managed to reduce to moderate, and this is the echo prior to the procedure, and at discharge you can see that there is a significant reduction, and the continuous wave Doppler through the jet, it looks like a normal shape, where we can now more reliably assess the pulmonary pressures. So for me, I think that the key messages from the trial, considering the safety from transcatheter edge-to-edge repair and early referrals should be pursued. We cannot wait that long because we will make sure that there is a more favorable anatomy to be treated with this device to ensure also better procedural results and better outcomes for the patient. And if anatomically is not ideal after trying to optimize the patient, think about other available treatments and search for the expertise in order to improve the outcomes of these patients.
Thank you very much, Victoria. It was very nice to have also the opportunity to see that we have the TT, but there are other opportunities to treat the tricuspid regurg. Maybe I can start with one or two questions, and we have also a lot of questions coming on the iPad. The first one maybe is, do you think that when we assess a patient in the echo lab, do we have to assess this patient several times or one is enough?
I think that you need to assess it several times because it's important to optimize medical therapy. We come from an area where we had only perhaps diuretics and we were not thinking too much on trying to get as dry as possible the patients, but we need really to hammer that outcome. We need to make sure the patient is really well decongested. And that will even improve the hemodynamics of the right side. We can improve as well the right ventricular systolic function, and that can also make a better assessment of which is the condition of the patient. So I think that evaluating twice with a transthoracic echocardiography doesn't harm. Actually, it makes probably a better selection of the patient for each therapy.
So we need several physicians, several techniques, several imaging, and the patients are complex. And we have a question about this patient with a severe and symptomatic TR. These patients most of the time have also some degree of MR. And how should we manage this MR? There is also a question about arrhythmias. Should we manage the arrhythmia or should we forget about the atrial fibrillation?
Well, I think at the moment it's an individual treatment decision for which we need this heart team. There's no evidence for that, but I mean clearly I would say if there's clearly a severe mitral regurgitation, this should be the first valve disorder to address. This should be the usual sequence. With regard to arrhythmia, and this is mostly atrial fibrillation, I would say, it's of course if you have torrential TR, I'm not sure if this is a patient who will benefit from an ablation. I mean, rhythm management, though, I mean, it's something we should consider in these patients, but maybe you should treat the valve first and then think about rhythm management, depending, of course, on atrial size and so on.
I think, Volker, a very difficult debate between treating the valve first or the atrial fibrillation first. That's something probably we need more data on. Just one question to both of you, maybe regarding the result of the study in general, TRILUMINATE, TRI.Fr, the two randomized study we have on this treatment. What we see is a very impressive effect on quality of life. But when I just look at your case, Victoria, for example, reducing this massive torrential TR to almost mild or moderate, I imagine that this will increase also a lot the cardiac output of the patient and probably have also an impact on the outcome. What is, in your opinion, maybe both of you, short answer for a difficult question, what is, in your opinion, missing that we really see this difference in terms of mortality or of rehospitalization?
Well, that's a very good question, and I think that is what we are always trying to pursue, see the hard endpoints. But I think that tricuspid regurgitation is a disease that, left untreated will lead a worse outcome, but you will not see that worse outcome in 12 months. Probably you need to wait longer. And an important factor also is to try to treat it and see this improvement symptomatically, because if the patient can even get a better shape after you solve the problem, so many times the symptoms that we have, we focus very much on the NIA class, but these patients, they have liver pain sometimes because they have the congested liver. And if they cannot even walk, it goes into a spiral that impacts very much on the frailty of these patients. So I think that a first step showing improvement on the quality of life and improvement in the shape of the patient on the frailty, that will lead later on probably to an improvement as well in mortality or in survival. But I think that we need perhaps to follow up these patients for a longer term follow-up.
Thank you, Victoria. We have questions also about the assessment of the gap. Which view do we use for that? And also, of course, a question about the assessment of the RV function. Is it something that we have to take into account, and how do we do so?
Yeah, that's always important. As we have been saying, the most important first, try to get the image with the patient as dry as possible. That will make an impact, particularly not only on the gap, but also on the right ventricular function. And it's going to be less misleading than when you do the echocardiogram with the patient still congested. Then for measuring the gap, considering the anatomy of the tricuspid valve, you should measure it at least in 2 different views if you are using 2-dimensional echocardiography. So one in the longitudinal view, perhaps on the apical 4-chamber view, but then as well on the short axis view from the parasternal view, you should also evaluate there the gap. If you have possibility of 3-dimensional echocardiography, then you can see the end phase view and you can measure there the biplanimetry. But I think that 2 perpendicular views would be advisable.
And the RV function, should we need to do a CMR or something else to assess the function? Or?
Well, I think that if you have the CMR and there are no contraindications, is much better because it's considered the reference standard for measuring the volumes of the ventricle. But 3-dimensional echocardiography nowadays can also be a very suitable solution. And I think that other parameters that consider as well the right ventricular coupling, such as, for example, the correction of the TAPSE versus the estimated pulmonary arterial pressure, could be also another measurement which has been associated with outcomes.
Maybe one question to you, Volker, because there is not only edge-to-edge repair, so we have other options, and many centers have several options. Victoria just showed an annuloplasty case, but there is also replacement approved in Europe and in the US as well. So what is your selection? How do you handle these different devices? Are you doing edge-to-edge first, if possible, because of the safety, or are you considering replacement earlier? How do you see this field evolving in the future?
I mean, I think certainly given the safety, edge-to-edge repair is somehow the first choice. However, I think what we have to consider, if you do it, there are not so many options after it. If you fail with the procedure, you know, what are you doing then? Then it's becoming difficult. And therefore, I think we have to be more considerate in choosing these patients because we have the option of, as Victoria showed, annuloplasty or replacement, which also has very good data with regard to symptom improvement, where we can treat these patients just simply better.
There are some clinical factors that you use, Erwan, in your study as well. That was a little bit different from Teluminate. How do you see this also, you know, with different devices regarding liver dysfunction, renal dysfunction, the use of antithrombotic treatment as well? Is there something you consider there in the way you choose your device?
That's a very difficult question, I think, because of course we can use the transcatheter valve replacement, but it's not suitable for every single patient. It's like for TT. So we really have patients that are suitable for the replacement and patients that are suitable for the TT. According to the renal dysfunction, for sure, if we have to implant a prosthesis, we have to take into account the fact that we use anticoagulation for all the life of the patient. So that's really something that we don't know yet because we don't have enough experience with the use of the prosthesis. But it might be an issue when the patient becomes sicker, that is, when we implant the valve. So we still have to learn a lot. I think we still need experts, actually. And managing patients with tricuspid regurg is extremely difficult. we saw that in the studies, but in real life, it's also extremely difficult. And we still need the PCR focus group to learn more. Don't you think so?
Yeah, no, but thank you very much, I mean, for advancing this field, for showing us this fantastic data on patients with edge-to-edge repair in France. So I think we have learned a lot during this webinar. We have learned that we need to look at clinical criteria for selecting patients. We need to look at the anatomy. We need to look at the stage of the disease and maybe to treat also patient earlier. So we need to really an expertise looking at all these parameters for selecting the right device. And of course, what we learned from TRI.Fr is that these patients can be helped with this therapy and have a very impressive improvement in their quality of life that is really important for them in their daily life. So I want to thank everybody for being here in Paris with me and for having this fantastic webinar. I want to thank everybody also in the audience. And I say see you soon for the next study, actually. Volker, I think you will be involved in the next webinar looking at the TRISCEND study, the replacement study. So we are very looking forward to this and wish you a very good evening. Thank you very much.